You're ready to go.
You're good?
You're good.
Okay. Well, first I'll just tell you who I am. I am Ryan Rapier. I am the marketing director and public relations director for the hospital. I have been there for just over a decade. So I've been around healthcare. When I was asked to come and speak on this, she left it very open. And the truth is, we could talk for 2 full semesters and barely scratch the surface of all the things you could talk about in healthcare. So she said it was tied to the book, The Jungle by Upton Sinclair. She gave me some areas where that tied in. I went and read those select chapters and decided that was possibly the most depressing book I'd ever read in my life in just those couple chapters. So I didn't read the rest of the book. I'm going to be upfront about that. But I thought I would touch on some things that kind of relate to the issues that those individuals were facing. Here's all the things, the little fine print. You can't have a discussion about healthcare today without touching on some issues that are political in nature. I will tell you right now, at this point in my life, have realized I am probably conservative moderate. I am somewhere there. If you are very conservative, by the end of this night, you will probably see me as a raging liberal. If you are liberal, you will see me as a wishy-washy moderate. I'm probably not going to be very popular with any political leanings because it's just not that easy of a subject to put into a box. But having said that, okay, let's pretend that it worked literally 10 minutes ago. Does anyone have any idea why? There we go. Okay, here's some of the things when it comes to the challenges faced by, let's be honest, those in poverty levels, those who are poor, and those who are middle class in the United States. For those individuals, we have some protective safety nets. There is a federal law called EMTALA, the Emergency Medical Treatment and Labor Act. That law stipulates that if you go to any hospital and you are what's called emergent, you are having an emergency, or if you are in labor, that hospital is required to take care of you and get you out of that state before they can discuss any kind of payment or anything. You cannot discuss money until those things have been taken care of.
So does labor mean pregnancy then? It doesn't mean work.
Correct. Nine months in labor.
Yeah.
Not treatment and those who are working. Light labor. The ACA, Affordable Care Act, otherwise known as Obamacare. We're all pretty familiar with that. Was put out there to help people who could not get on Medicare, but had struggled with paying for insurance. This was kind of a safety net. There were ways that the government could help subsidize people purchasing. There's Medicare for those under a certain level who qualify. You can get on Medicare, which is federal dollars and state dollars that provide, I'm talking Medicaid, which is run by Access in Arizona. Medicare, health care for those who are 65 or older. And the VA. This will be the one and only mention of the VA. It is a separate issue and entity unto itself, but that is a safety net for those who have served their country. The challenges we're facing for that group, those groups that we talked about, high deductibles that amount to very little coverage. I think that's probably the number one concern you hear out there about the ACA. The other is soaring premiums. It seems like what you paid $200 for last year, you're going to pay $400 for this year, and maybe $600 next year. On the flip side, the reason you're having these issues is how are state governments, hospitals, and federal government programs going to stay solvent? How are they going to pay the bills? How are they going to meet all their issues with the money that's available? And then, how do you get adequate care for the uninsured or the underinsured? Those are really the issues we face. Please understand, I recognize we're in a college setting. That tends to be a lecture. I hate lectures. If at any point, and I appreciate you for doing so, raise the hands, ask any questions. If something doesn't make sense, ask me. If you have a comment, think I'm wrong. I am not a healthcare expert. I once had a situation where someone in a religious setting told me, if someone tells you that they know everything there is to know about the book of Revelation, don't listen to a word they say, because they'll probably lie to you about other things too. And that is healthcare. If anybody tells you they are a healthcare expert and can explain, I'd be a little dubious, because I'm not sure they exist. First thing I want to talk about is a lot of what dictates what you will be billed or what you pay when you go to a hospital or a doctor all ties back to Medicare. You may be 25 years old going to get an MRI, and likely what you pay has very much to do with Medicare. And here's why. I've used some approximate figures just to give you examples. These aren't actual costs, but just Mount Graham Regional Medical Center. To provide an MRI on your knee, let's say it needs to make $800 to cover its costs. Yes?
So is that a for-profit organization, or is it not?
Mount Graham Regional Medical Center is a not-for-profit, community-owned hospital.
So it's a break-even operation. So you say it's cost. Yeah.
In other words, to cover its cost, to cover the employee, and we'll get into this in just a little bit after I've explained this. But sometimes what you can get paid for something like an MRI has to not only cover your costs in the MRI in a hospital, but also in the labor and delivery room where you don't get paid enough to cover your costs, or in the emergency room where some people come and they're never going to pay their bill. It's not fair, but some of you may have run into this. You can go to our hospital and be billed $2,200 for an MRI, and yet you heard from your friend that they went down to Tucson and paid $400 for an MRI. How is that possible? Well, we're going to go through this right here, but also you're running into the fact that an outpatient imaging center has no other areas that they have to cover their losses, whereas a hospital does. So, $800 to cover its costs. Centers for Medicare and Medicaid Services, otherwise known as CMS, agrees to pay Mount Graham Regional Medical Center 40% of whatever we bill them for an MRI. So, that means we have to raise the price so that when they cut off the 60% they're not going to pay us, we still get our $800. Private insurance then looks at, all private insurance works off of Medicare guidelines. So all private insurances are doing the same thing. They pay better than Medicare, but they start with Medicare as a baseline, look at the service and say, well, we'll pay you this much. 50%, 55%. Each company is different, but they're all starting with CMS guidelines. So that all sounds well and good, except that CMS has a nasty little rule in there. If Sean, and since I know Sean's name, I'm going to point to him and call him out. Yeah, the guy in the ASU shirt. If Sean comes in and needs an MRI, and we're billing $2,000 so that we can get our $800 to Medicare patients, as the hospital, Sean, who doesn't have any insurance whatsoever, I still have to bill him $2,000. Have to. Because if I don't pay him or charge him $2,000, CMS will come and look at that and say, you billed somebody else less than you billed us, we're taking the money back. Not just for one person, they will take a week-long period, a month-long period, some large amount of time, and any money that Medicare has paid to us as a hospital for that period of time, they're taking it all back. So as a hospital, we have no other recourse than to charge someone like Sean, not actually like Sean, but in Sean's situation, who is a self-pay because they can't afford the premiums on a health plan, or who is underinsured and has a very high deductible, we have to charge him the full $2,000. The only situation where we can give Sean a break is if he has the cash in hand to pay right then. We can cut him some discount. We can give him a discount. If he cannot do that, he goes on a payment plan and he will pay the full $2,000. Does that make any sense? Okay. Now,
Can you negotiate? Can you get a political elections and then say, well, what does it need to satisfy these benefits? Can you play a game like that or not?
if you run that risk, you might be successful, but if Medicare catches wind of it, you're sunk. Any games you try to play to help people out, you're running the risk of serious losses. Now, all of this worked great in the 1980s and 1990s when Medicare was giving 80%, 70% of what we charged. We could charge $950 and they'd pay us $800 for that MRI. But as time went along, healthcare got more expensive. That's what has been driving up a lot of your costs. One thing that's been driving up a lot of your costs. So what's affecting Medicare to make these changes? In 2010, 13% of our American population was 65 or older. By 2030, 19% of our American population will be 65 and older and working off of that Medicare pot. That's quite a number reaching into the same pot of money. The reason we use 2030 is because that is when all baby boomers will have hit the 65 age. Now, 80 million is the total number of American baby boomers we have in this country. Those that were born between 1945 and 1946. Where it gets difficult is my generation, the Generation Xers, born between 65 and 80, there was only 46 million of us. So us paying into the system versus those now reaching into the system is much different. When all the baby boomers were paying into the system and those above were taking out, it was a much better situation. Now you're top heavy. And that leads to cuts in Medicare and increased costs. Total Medicare spending. In 2015, $646 billion was spent on Medicare costs by the federal government, as opposed to 2010, which was still a huge number, but it is $120 billion left. I can do quite a bit with $120 billion. But compare that to 2000 when we spent $219 billion. That's exponential, and it's not slowing down. It's not going to slow down. Medicare spending is estimated to grow at a rate of 4.5% per capita every year over the next decade. Over a quarter of your Medicare spending is directed towards patients in the final year of life. Now here's an interesting stat. You would think that that would mean a lot of your Medicare spending is going to those 80, 90-year-olds who are past. It's actually going, almost a majority of Medicare spending is going to those who are between 65 and 75 who are in the last year of their life. Now, there's a lot of reasons you could come up with. What is kind of a common thing, a consensus thought. In 1950, you made it to 65. Good for you. Anything after that was gravy. You made it to 75. Wow. Today, when people hit 65, the message that society gives is, hey, you're just getting started. You've got 30 years. And so if you're 66, if you're 68, if you're 70, and you receive a diagnosis that says you're not going to get those extra years, you're doing everything you can because life has been promised to you for much longer than this. This is not right. It's not my time, even though sometimes it is. But we're seeing after 75 more of an acceptance that, okay, this is the natural order of things. But that 65 to 75 use of Medicare of people who are in the last year of their life is about 40% of Medicare spending. Yeah.
Have you ever discussed capping the amount of that each individual can have for Medicare?
I'm sure someone has discussed it. And if it was a Republican, the Democrats immediately started their campaign of how they were going to come out with Republicans are going to kill grandma. That's the political reality that we're faced with. Whichever party suggests doing one thing to stop this, or in any way suggests cutting those coverages, the other party has got their issue, because senior citizens are by far the most likely to vote demographic, and they do. And so I'm sure the discussions have been held. We have never heard anything to suggest that it's gone anywhere. Does that answer your question? Okay, so how does that affect us, those of us who aren't on Medicare? Politicians are hesitant to pass along a 4.5% increase to the most active voting population in America. They're not willing to tell people 65 and older, okay, you paid into this system for all these years, and we told you you'd be pretty much covered, but now you're going to have to pay X amount more every year for your services. They do have some increases, but not anywhere near 4.5%. So what do? To offset the increases that can't be passed along, they turn around and they come back to hospitals where they used to pay us 85% for an MRI of what we billed. We're going to cut you by 10%. Then 2 years later, we're going to cut you by 5% this year. We're going to take another, and that's what you've seen on Medicare. On Medicaid, it's been significantly worse. So just to give you an idea of how that affects our example of Sean, the uninsured, if CMS lowers their reimbursement for an MRI from 40% of a billed amount to 30% of the billed amount, that $2,000 MRI just went to be $2,700 MRI for the self-pay patient. So if you desperately need an MRI, or what often happens, you come into the hospital through the emergency room, you don't have insurance. In order to find out what's wrong with you, we give you an MRI. We turn around and bill you $2,700, and you don't have $2,700. What happens? We don't get paid. And it results in what we call charity care, or care that is just provided for free. It's something we plan on, it's something we budget into the system, because it's a reality of life. I hate to sound cynical, but if you say the word self-pay at the hospital, even though there are some very good people who are self-pay and would pay their bills, the general response you'll get at the hospital is self-pay means non-pay. It's just going to go right out the door.
I have a question.
Yeah.
What percentage of cases you guys see at Mount Graham Medical Center that are self-pay? Like in a given year, what percentage?
I can't give you cases. I am going to talk about numbers of how much dollar amounts of what we do charity care. Will that cover you? Because I don't know percentage wise, and it's very different month to month. But it's tough because a lot of the things that you would think would be self-pay can be qualified for Medicaid. And if we think they can, we will have somebody come in and try to get them signed up and get them on Medicaid so that we in some way can get paid something. Okay, so if it goes to charity care, MGRMC still needs that $800 to cover the costs of the MRI that we just gave.
I have a question.
Yeah.
So if Medicare is saying they will only pay basically 30% or $800, and everyone's increasing their costs, isn't Medicare still paying out about the same amount of money because everyone raised their costs because they lowered their percentage?
That's in a perfect world, we could get them to do that. But Medicare's smarter than that, and you can't raise your rates a certain percentage, and certain things, it's not even a percentage. We will pay up to 30% and then cap it here. I mean, they have a lot of things in place. I'm giving you a very basic, it's kind of like our tax code. I could show you the 7 tax brackets, but there's a whole lot more to it. But yes, your point is right. If everybody keeps raising their prices to get the same amount, that's kind of a little bit what happens, but they do have a way of keeping you from going out of whack. Sure.
Is there such a thing so-called
Not that I'm aware of.
so much healthcare that has to be in a way free for each one?
If there is, we don't have any problem hitting it.
I don't think anyone.
Yeah. I'm not aware of a number that we have to hit.
Oh, but have you heard of that? You hear you're saying that you don't give them the you know you're doing
It might be, to be completely honest, it might be. In the time I've been at Mount Graham, if that's on the books, it's never been an issue because of what we run into, so I've never heard it discussed.
So basically, so if someone comes into the emergency room and they're in a state of shock or whatever, you have to treat them.
Yes, yes, and do whatever it takes to.
That you do that. And so they may come and get that treatment and then never pay a dime for it because they think it's an emergency state.
Correct.
So you're talking all these higher things or what's going to so-called cover the costs for what they did in the emergency.
Well, in other words,
What happens
we
if-
have to recoup enough to make money, and we have to find a way to do it. So what are the results? Basically what we're talking about here, higher price for services. The other thing every hospital has to do, we've done it many times over the last 10 years, we got to lower costs. And what that means for a hospital is you have to reduce staff. We've done that. And you have to figure out what's not making you money. And if you can, you got to get rid of it.
So is that like, for example, down here in this area, if you didn't give any MRI services for 2 years, you just scrap the MRI machine completely? Is that
If we were not making money on MRI services, then we would consider that, yes. Now, the truth of the matter is MRI happens to be the way insurances pay right now, one of the best things you can have, because they will pay pretty well on MRIs, CAT scans, x-rays, ultrasounds. They pay very well for surgery. Where you will just get hit hard, and what we did, January 2016, home health services. We were losing roughly $700,000 a year on home health services, and that was being offset by the other areas where we were making money. We couldn't do it anymore. So we transferred them to an outside company, and we no longer have home health and hospice. We have hospice only. Another thing that was an odd situation at the hospital, it was ours, but we didn't run it. But you may have seen in the paper, we had a therapeutic heated pool in the Roadrunner rehabilitation area. We had a large, and by large, I mean about 40 individuals from our senior citizens in this area who regularly used it. They loved it. It was as much a social thing as it was a rehabilitation thing. It was the only one in town. It cost us $70,000 just a year to maintain, and we saw nothing in return for that. We tried 8 years ago to get rid of the pool, and the public outcry was such that we backed off. But as the economic climate continued to deteriorate, when it came November of last year, even though the public outcry was there once again, we had to say, we're sorry, it's going away. We can't do it anymore. And that's what you're seeing, especially in rural hospitals and hospitals in poorer urban areas. They're cutting all kinds of things. We're lucky here in Safford because we have a better mix of private insurance because of the college, because of Freeport-McMoran especially, and others. We can handle some things. What you are seeing in other rural areas is ICUs go away because they pay okay, but the amount of cost that it takes to take care of some of the people in ICU can't handle. Another one that is just costly and is very hard to make money at, and the insurance, the word, I can't, anyway, is labor and delivery. It's really hard to make money in that area. Yeah.
Was that a therapeutic vehicle?
No. No, it was something we had provided that there was no way for us to even charge for it. And so it was a free service.
We had a case when I went in for therapy, and the doctor said physical therapy, but when we got to Roadrunner, they changed it to office therapy, and it was awfully expensive. And then it turned out that the interest of it, well, we handle physical therapy, but we don't handle office therapy. So then it took us a little while to
get that all straightened out.
Get that straightened out, yeah.
And that was kind of where we were at. That Roadrunner operated it, and they're a separate entity from the hospital, and they would make what they could off of it. They weren't making anything. We were paying for it because it was our pool, and it just wasn't working. Okay, charity care. In 2000, we're going to do a little bit of history here. In 2000, Arizona voters passed a ballot initiative requiring Arizona to cover all residents through the Access Plan up to 100% of the poverty line. Whatever was deemed the poverty line, Access had to cover those individuals. In 2011, to balance the budget after, give you a little bit of outside, Arizona's legislature cut taxes a great deal between 2000 and 2008, and pretty much had banked everything on the growth that they were seeing as far as home building and things like that. That was where a large majority of the tax revenue was coming for the state. Well, anybody remember 2008? Devastating the housing market. Arizona's tax base went right through the floor, and suddenly the state didn't have money to pay for anything. And so to balance the budget in 2011, the legislature passed a bill aiming to remove 250 people from the Access rolls by lowering the coverage to 2/3 of the poverty line. The issue was, by 2011, the ACA, or Obamacare, had already been passed, and so they knew that come 2014, they would have to put all those people back plus more because Obamacare required coverage up to 133% in order to get federal funding. They fought, they went through the courts. As it turned out, they did not get 250,000 removed. They ended up removing 140,000 people, childless adults. That was really the big kicker, is they wanted to take everybody in this line, and Health and Human Services said you can't take people, you can't take kids, and you can't take parents with kids. So they ended up removing 140,000 people from the rolls. Forward 3 years, Arizona's legislature said, we know we're supposed to raise it back up, and we know that the government says they're going to give us $7.1 billion, but we don't believe them. We don't think the money's there, so we're not going to do it. In which case, $7.1 billion sent to Arizona would have gone away, would have gone to Utah, would have gone to California, would have gone to New Mexico. Governor Brewer, the Democrats, and a handful of Republicans basically came together and said, we can't afford to lose $7.1 billion of funding to Arizona, and that's over the course of 10 years. Yeah.
Was that funding specific towards healthcare? Did that go to education, infrastructure? Was it just
Medicaid spending.
Just Medicaid?
Medicaid only. So they pushed through a bill that raised the line of access coverage back up to 133%. And that allowed that $7.1 billion over the next 10 years to now come back to Arizona. The reason I mention this is in the years leading up to 2011, our average annual charity care that we gave away was $800,000. But as soon as they dropped those 140,000 people from the Medicaid rolls, the access rolls, our charity care doubled in the years of 2012 and 2013 to 1.6 million. So what does that basically mean? Yeah, you saved money at the legislature, but at the hospital level, we're losing all this money. That money has to be recouped somewhere back to the people who pay the taxes in the first place. They're just paying it somewhere else. When they put this back in place in 2014, in the 3 years since, we've seen our charity care come back down into that $815,000 range. So what will happen when you take people off of Medicaid rolls? And this is where I'm going to sound very Democrat in my approach, but when you take people off of Medicaid rolls, they don't stop getting sick. But now they don't have insurance to go to their primary care physician, whether that be Gila Valley Clinic or any of the clinics in town. So they get sicker, and they get sicker until they can't ignore it anymore, and they come to the emergency room. And they are emergent, and we have to treat them. And they are way worse than what they would have been had they just gone to their doctor, and the cost is more to take care of the issue at that point. That's the most common thing you see.
So if you were taken off the Medicare line, like what was it, a third of them were taken off in 2000.
Well, that was the aim. They ended up about a fourth. But yeah, your point is
140,000 people you got. And they go to the hospital. They don't have Medicare anymore. They go to the hospital. They go down here, and then they get on MRI, they get surgery, and they leave. Will they ever have to repay that, or is that all in taxpayer time?
We do just like any other business. We bill them, and we bill them, and we send them to collections. I mean, we do what everybody else does, but they have a specific bankruptcy specific to healthcare costs. And you don't really have to lose what you lose in a regular bankruptcy if you go through that bankruptcy. So if you don't have much and you just don't have it to pay, in essence, the answer is no, they don't have to pay it eventually. Now, most people, to be fair, a lot of people would make an effort, and not everybody's a deadbeat. I'm not trying to imply that, but
let's just say that everyone here said, you know, I'm sick of paying for healthcare. Let's just stop. Let's just go to the emergency room, not pay for healthcare. Forget all the bills in the mail. Forget all the collections, and just forget it. Isn't that easier? And what stops us from doing that?
Hopefully you don't talk to anybody. No,
I'm just saying I feel like
the safety nets, because how often do you, as a 20-something-year-old, or I'm assuming you're 20-something,
21
how often are you sick?
feels pretty healthy.
Pretty much never. You're the most uninsured group of people. So, and you can stay on your parents' plan under the ACA until you're 26. Medicare covers the really, really poor. I know that a lot of people were negative towards the ACA, but you did see a lot of them get on insurance plans, and so there was that effort. Medicare covers a lot of your really sick people. I mean, so there's a lot of things where people are paying through insurance. The number of self-pay, I think, to be quite honest, are doing exactly what you say. Those who don't have insurance are doing exactly what you're saying. It's just not a significant portion of the population to implode the whole system.
Going off of that, I'm sure we don't know the number, maybe we do, but how many people could afford it that don't want to, like I said?
That's a great question. And that's, let's continue on with our conversation. Hold on to that. Yeah.
So the goal is to treat these people early, you know, keep them out of the ER once they get so sick that it costs so much more. How good are the doctors in the clinics to work with these people who don't have insurance? Are they going to see them on their self-pay, can't pay that bill right now?
I would defy you to get off your, don't do this, but try going and getting a doctor in this town without insurance. They won't even, you can't.
And so it's like, what are they supposed
So
to
I don't want to say forced us, we tried to do what was right for the community. I don't know if you've ever heard of the Copper Mountain Clinic, but it's a clinic that we own as a hospital, and we do get some different reimbursement rates from the state to help us stay open. But that was our biggest problem. We would get people into the hospital. We couldn't release them because you need a doctor to release them too. We couldn't release them. Or people we knew needed follow-up care, and they were just going to walk out the door and there was nothing we could do. So we opened that clinic specifically for that purpose. And they can go there, and we have different avenues to help them pay or work through that other clinics don't. Does that answer your question? Okay, just some interesting numbers. Annual average premium in a year you could expect to pay if you had you and your family covered in 1999 was $5,791. In 2008, roughly 10 years, that jumped from $5,791 to $12,680. In 8 years, that jumped another $6,000 to $18,142. So, percentage increase in premiums from 2001 to 2006, 63%. Percentage increase from 2006 to 2011, 31%. 2011 to 2016, 20%. Why do I show you that? Because one of the biggest problems, or one of the things you hear most about the Affordable Care Act is, it is broken, it doesn't work, it is causing premiums to skyrocket. Let's repeal it and go back to the good old days. You mean the good old days when we were jumping from 63%? Or the good old days, 31%? You actually saw a drop in the overall percentage of premium increase once the ACA was passed. The implication is that had it not passed, premiums would have skyrocketed, possibly even further. It kind of worked. The problem was, the promise of the ACA was premiums will go down, and it didn't. And it's because the system itself had to run a certain way, and it didn't. We'll talk about that in just a second. Yeah.
So like
you see the jump from like 1999 to 2016, even 2008, that it costs so much to cover your insurance, and that's what the like parent is paying, right?
Mhm.
So they're paying to their insurance company to have insurance, is that right?
For instance, at the hospital, I have benefits,
Mhm.
and each month I pay $360.
Mhm.
The hospital also pays an additional $800 or something like that. All of that together makes up those numbers.
You said it earlier, but like, is it raising because Medicare is like staying the same? It's not willing to like be like, oh, we'll pay 50% instead of the 40%. Is the cost getting higher because of that? Or is it
The
just
sad
Medicare?
part of what I'm going to tell you tonight is that we really want someone to blame,
Mhm.
and there isn't anybody. And here's your problem. 1999, U.S. population, 279 million people. Population in 2016, 323 million people. So here's the really interesting part. Your births didn't go up, which means we're not growing because we're having more babies. Our population is getting older. We're living longer. We're coming up with amazing new technologies to keep people alive. But in order to come up with new technologies, it costs money.
So looking at this, 280 million, and then now there's, so that's about 15 years, and yet at 4 million births a year, that's 60 million people being born, and that difference between those two is only 40 million. So the
40,000.
Pardon me?
What are you talking about? Okay, I'm sorry. What are you saying?
Well, the birth rate is that it's the difference, right? It's not.
No, because people are also dying. They're just not dying at the same rate, is what I'm trying to get at. The number of births
Well, the difference-
has gone flat, whereas the number of deaths has not.
Well, but see, in 1 year, there's 4 million people born, so after 10 years, that would have been 40 million. But then you subtract 280 from 320, and that's 40 million.
Mhm.
So the population is just due to the, you don't.
But in your
have the
example,
mortality rate.
in your example, no one's died.
That's why you run the mortality rate. So that would make the number. Well, anyway.
The general gist, and I could have brought in a great, we're not dying. We're just not dying. Not that that's a bad thing, it's just that's what it is. So let's talk another little bit of history. In 1989, a group called the Heritage Foundation, which is a conservative think tank, proposed the idea of an individual mandate requiring all American families to secure a health insurance policy from a major private insurance provider. The Heritage Foundation says in order to do this, you do need to have a major reform of the tax system that would make this more feasible. It's 1989. George H.W. Bush is in place. 2006, Governor Mitt Romney, Republican governor of Massachusetts, passes a state-level individual mandate in Massachusetts. Dubbed Romney Care, it admits that the architect of this plan, where they took it from, was that original idea proposed by the Heritage Foundation. 2010, Barack Obama signs the ACA into law, which includes a federal individual mandate for all Americans to get health insurance. Those opting out of the mandate would be required to pay a fine that gradually increases year after year. The purpose of the mandate is this, and this kind of goes back to your question. In order for the ACA to work and to bring down premiums, you needed to pay in. You needed to pay in. My daughter, who just graduated from high school, she needs to get with the program and start paying in, because healthy people paying in is the only way this works. If you don't have healthy people paying in, then the new absorbing of costs for those with pre-existing conditions and those who are aging and getting sick weighs down the system. Other things that were in the Affordable Care Act is they started to want to focus on preventative care. I'm actually very much a proponent of freedom. I love freedom, and I know that that's a big sticking point when it comes to the individual mandate. No one wants to be told, you will pay this, you will have this plan. Here's the thing that comes with freedom. It's called consequences, and that's where our country is struggling. I want to eat my bonbons and my ice cream, and I want to smoke, and I want to do, you can't tell me what to do. Oh crud, I've got emphysema at 65 and I've got type 2 diabetes. You need to pay for all my problems. I need you to cover me for all these things that I did to myself. Wait a minute, if we're talking freedom, maybe you need to pay for all these things you did to yourself. But that's not a realistic thing. That's not how human beings work. So they wanted to make insurance companies focus on preventative care. Now, I don't know how many of you have had to do this, but if any of you have health benefits, it used to be you signed up and that's the last you thought about it. Now, a lot of times in companies, they will have know your numbers days where they come in and they prick your finger and they weigh you and they tell you, this is good, this is good, this is bad, this is really bad, you need to take care of these things. And they will tie it at the hospital. They tied our we're on a health savings account, and the hospital gives us a certain amount of money every year into that health savings account. They give us one part. The other part is tied to taking part in these know your number days and things like that. So they're in essence forcing us into preventative care. They required a higher state contribution to Medicaid. Customer service roles. Oh, I'm sorry. Something we saw at the hospital. No longer could you have the days where the doctor walks in, treats you not that great, but because he's a doctor, you have to take it. Customer service scores were directly tied to how hospitals would be reimbursed. We would have to do studies, surveys, after your visit to the hospital. How was your stay? Was your doctor communicative? Was your nurse communicative? Was the hospital clean? They would ask a number of questions. We would have to turn that information into CMS, who would then turn around and compare it against all the other hospitals in Arizona. How you did versus those other hospitals in Arizona initially was going to decide how you got paid. If you were in the top, you got a little bonus. If you're in the middle, you got paid normal. If you were in the bottom, you took a cut. So suddenly hospitals are going, oh my gosh, we can't just do what we've always done. We've got to treat these people nice. We've got to make them happy. So that was something that was brought on through the ACA. Coverage had to be extended to children up to 26 years of age, and pre-existing conditions must be accepted by insurance companies. Where the ACA failed. Despite a slowing rate of increase, premiums have still risen 20%, and while that's less than 63%, that's a lot. And families are really taking, and to be quite fair, 20% of 12,000 is a lot more than, or is a greater number than 20% of 5,000. So that 63 versus 20 can be skewed a little bit. The mandate. What they did not expect is that they didn't, from their point of view, they did not make the fines big enough. Year number one, the number of people who chose to take the fine was insane. It was so much more than they anticipated. Now, if you're a self-paid person who's struggling to make ends meet, and these are your options, you need to go buy a policy for your family that's going to cost $1,200 a month. Or you're going to have to pay a $200 fine. And the only way we're going to be able to get that fine is through your tax refund. What you going to do? Think I'll have you take it out of my tax refund? I'm good. That that was a huge issue. Also, shrinking marketplace. Because of what happened with the lower premiums, because of what happened with the mandate and fewer people coming in, private insurances started to realize we can't make any money. The number of people that were going to buy in and make all this possible, they're not showing up. We're out. You're seeing that in a lot of states. Having an option is no longer the case. In a lot of states, you have one choice. One that has managed to stay in the exchange. So now I'm going to tell you my opinion. I'm going to step away and I'm going to give you my opinion as a person who has been in healthcare of what really it would take to fix our healthcare system. My opinion is there are a lot of good ideas in the Affordable Care Act. There were some things that were not great. I know in the program it said we would talk about the bill that they were looking to pass. It's dead. There's really not a lot of reason to go into it. But what that would have done was turned a lot of money back to the states. But they would have looked at where your Medicare coverage, Medicaid coverages were at prior to 2014. We were way low. We would have had a lot of money taken back. And we would not have received the same. We would have lost a lot. And they would have turned it over to the legislature. And I mean no disrespect. I'm not disrespecting either party. I guess I'm just disrespecting politicians in general. Our legislature has proven that we can vote for teacher salary increases as voters, and yet still our teachers don't seem to manage to get salary increases. So just because you turn money back to the states doesn't mean that's going to fix everything either. So here are some things that I think if you really wanted to see healthcare costs improve, one of the things that's going to have to happen is tort reform. They're going to have to find a way to cap punitive damages in lawsuits. If a doctor screws up, by all means, they should be held to account for the costs that those people incurred to have it fixed. They should pay all of that. There's even a situation, I mean, I can understand where charge them a little bit more just to make them hurt a little bit, but those have got to be capped. The number that's generally thrown out is $250,000. Cap it there. There is no doctor on earth, and doctors are human beings, and just like the rest of us, if I mess up at work, I come to you and I have a PowerPoint presentation with transposed letters. It doesn't matter a whole lot. When a doctor messes up, it hurts people. But they can't afford a $10 million lawsuit. Yeah.
Have you heard of any serious attempts by politicians to
it was a big deal in the 90s. It was part of their agenda back then. During the Obama administration, that discussion all but died. The trial lawyers group tends to favor the Democrat Party, and so while they were in power, it was pretty much non-existent. But for whatever reason, that has not come up with our new administration at all. Yeah.
One, the doctors get something from the pharmaceutical company. So writing out
Not anymore. Since the passage of the anti-kickback law. That was back in the 90s. I'm dead serious. They can still have them come in, and they do nice things for them. They can buy them lunch, but those days of taking them out for golf and paying them under the table, does it happen? I'm sure it probably does. Just like we found out with the NCAA this week, there's a lot of things that aren't supposed to be happening in college basketball, but it's happening. So I'm not saying it doesn't happen, but that law called the Stark Law. Our general surgeon at Mount Graham Regional Medical Center does not work for us. He has his own private practice. But he will do things in our hospital. He will do procedures that benefit us. But if we run an advertisement that only we pay for, we can't mention his name because we're providing him with a benefit. So pharmaceutical companies have been severely limited. It used to be the Wild West when it came to drug companies, but it actually is not near what it used to be.
And what about with Obama? He got millions on the Obamacare. Where did that come? I didn't see it in the breakdown.
What do you mean got millions?
He got millions. So much per person that signed up for it. That's a long fact. 10 person. Got millions.
I don't know anything about that.
Yeah, that should be in that breakdown.
I have,
That comes from somewhere.
well, I'm sure that it's out there, but I have never seen anything that indicates that. Malpractice insurance currently in our country ranges from 10 to 20% of an average physician's salary. And that is to cover those costs of those astronomical verdicts. And in some states, it's way worse. They have an obstetrician shortage in Mississippi because the malpractice insurance for an OBGYN in Mississippi is so punitive that there's just no point in trying to do business in Mississippi as an obstetrician. This I find very funny. A hard reality is Republicans for a long time have advocated people need to take personal responsibility. That's the only way we're going to deal with this. The ACA actually had in it at one point commissions that would look at the need versus other factors. For instance, if you have a 79-year-old with heart failure and is getting treatment for renal failure and they need a full knee replacement, maybe Medicare shouldn't pay for a full knee replacement. Maybe if you want a full knee replacement, you can pay for it. We're not going to turn you down if you want to pay for it. But should the taxpayers be covering every little thing? And that's what those commissions were designed to do. It was mind-boggling to me because that honestly is something that you're going to have happen. As the population gets older, there has to be someone or some guidelines that say, in these certain situations, we just can't afford to pay for some of these things that you're wanting us to do. Of all people, Sarah Palin was the one who came out and called those death panels. That was interesting. Another thing we really need to look at is a pharmaceutical overhaul. The average cost of producing a new drug that gets to the marketplace is $2.6 billion. Pharmaceutical companies, from the day they get their patent, have 20 years to recoup all of that cost. That sounds reasonable, except that's not the day that it goes to market. That's the day that they think, oh, I think we've got it. They put a patent on it. They then have to go out and get all the research done in order to get it past the Food and Drug Administration. That takes a minimum generally of 8 years or longer. So many times you're finding drug companies have 5 to 10 to maybe 12 years, if they're really lucky, to recoup that $2.6 billion on that drug before generics are then allowed to come in and basically cannibalize. That's a reality. That actually goes to his question. You could get pharmaceutical companies used to really put the pressure on and would sell those drugs to the docs and give them all kind of benefits to turn around and prescribe them. Because of that law that put so many restrictions in place, they couldn't do that anymore. And that is when you started seeing it goes straight to the buyer, so that the buyer will then turn around and go ask their doctor about it. So when we all started hearing this may cause death, somewhat of death, uncomfortable death. Yeah. So when you started seeing those commercials, that was a direct result of that law passing. By far, in my opinion, one of the most things we need to do is an overhaul of CMS and the insurance system of payment. Charging tens of thousands to make thousands and charging thousands to make hundreds is blatantly unfair to the uninsured and underinsured. It's ridiculous. It's not capitalism. It's a twisted mess. And it is forcing hospitals into this situation where we've discussed, I mean, we have to make a certain amount to not just pay for the MRI, but we've got to cover these other services that you need to have in a hospital. Well, that works until outpatient imaging centers come in and they start taking all your business. What do? What Mount Graham Regional Medical Center would be forced to do if it got to that point where we just could not make it based on the payments. We're in a situation where a community-owned hospital with a district board, and we could come to the community and say, we need to pass a tax, a property tax, that will generate, I think our cap is a little over $2 million a year, or we're shutting our doors. That would be where this would end up. But if you get rid of this system and just allow people to pay for the service that they're getting, that would solve a lot of our problems. This last one's a joke. It's never going to happen, and I'm not even suggesting that it should. But a lot of people are very scared of a universal healthcare system. I have lived in England, and I have seen the universal healthcare system in play, and it's not great. For daily aches, daily sore throat, things like that, it's fabulous. You walk in, you see a doctor, you walk out, you pay nothing, great. You get into more serious stuff, you can have some real problems. And people who are against a united healthcare system will often point to the fact that Canadians come across the border to get American healthcare, and Mexicans are coming across the border to get because our healthcare is so much better. But the group of people, no, drugs, you go the other way. But the people you don't see coming to America are Norwegians, the Swedes, because in those countries, they have taken their natural resources and made them national. They own the gas and oil in their countries. So Norway takes its gas and oil, sells it to the world, uses that money to pay for a healthcare system for their people. That works when you've got a tiny little population. We could do that. We probably have enough natural resources. We could do that ourselves, but then you'd have to really just jack our whole system of being, and I don't know if we're ready to go into that. But honestly, to take care of the costs of doing a universal healthcare system that won't be a mess, you'd probably have to look at doing something like that. In my opinion, again, these are all opinions on my part.
That opens the whole can of worms that you just said about,
Which is why it's never going to happen.
I lived in Germany, so I've seen way back. The left liberals, they don't want to mine or to frack for oil in Alaska. And you're proposing that, well, like you said, if we wanted to switch to socialism, we'd have to start fracking to pay for it. We'd have to go to Anwar. We'd have to do all kinds of stuff. We'd have to start to really, with 350 million people here, 323 million people here, we'd have to really start. And I'm not just talking oil. You'd have to be looking at timber, everything. And that's all stuff that, liberals are like. That's my disclaimer. This will never happen, nor should it. But I'm just trying to give you an idea. If you wanted a universal healthcare system that could handle itself, that could really pay for itself and not be a major burden on our population, you'd have to look at something like that. The catch-22 is if people want America to be a socialist healthcare system, they have to start going on natural resources completely, right? Or the other option is increase taxes, right? And I read that if we tax the 1% that makes $1 million a year or more, 100% in our country, we tax the 1% that makes that much, 100%. Everything they make goes to the federal government for this. It would keep, I think, Medicare afloat for 1 year. That money. For 1 year. And then if you did, again, if you taxed the 10%, and that's $250,000 a month per year. I think it's about 3.
Now,
Maybe
that,
you do that for a year.
and those numbers are right, but where they are a little flawed is if that is your only tax. In other words, if you cease taxing everyone else and only tax those, that's accurate. If you continue to tax, and obviously we're never going to tax anybody 100%, that's insane. But if you continue to tax people at the current rate, viability would become much, much greater. But we're not going to do that. And so we've now left the realm of reality in my presentation, and now we're talking.
But it's good food for thought to see how long it could possibly be sustained if we don't want to mine our resources.
Yeah. That's all I got. So I appreciate you coming tonight, and I hopefully you've learned something you didn't know before, or I didn't put you to sleep. So.
Well, thank you.
We possibly get a